Hey, good morning and good afternoon, everyone. My name is Peggy Diadamo, and I'm going to be the moderator of this webinar. And you can see a little bit about me on the slide. I work at USAID, and I've been there about 10 years. And I have been interested in digital technology for quite a long time. And I've seen interest grow at USAID and among all of our implementing partners tremendously over the last 10 years. So we're going to focus on digital technology for social and behavior change communication in family planning. And we thought we'd start with a poll, a couple of questions that we'll ask separately, just to get a sense of your knowledge of digital technology and when it's used for behavior change communication. So here's the first question. Go ahead and answer that. I'll give you a minute to answer. I can see how many answers there are. And while that's happening, I just wanted to let you know that there's a little bar over on the right-hand side of your screen. Down near the bottom says handouts. Someone asked where the handouts are. Those are down there. Okay, so let's see what the answer to the poll is now. Okay, so about half of the people who are on the call now have used digital technology and to promote family planning or to facilitate talking about family planning, and about half haven't. So that's great, because some of you already have a lot of information that you can share, and some of you probably have some questions. So let's go on to the next slide. This is just a little outline of what we'll be doing. I'm doing the welcome and the introduction right now. We have three presenters, or two presenters that are going to present together, followed by two more. So the first two will talk mostly about the brief that we drafted, and then the other two are going to present some information about studies or work that was actually cited in the brief. In one case, some work in Nigeria, and in the second case, some work in Mozambique. And we will take all the questions at the end, but if you want to type your questions in as we go along, you can do that by just opening up the question box and typing it in. And then we'll get back to them near the end. The webinar will be recorded, and you'll be able to you'll get an email afterwards that will send you the link. And if we don't answer all the questions, maybe we'll try to answer at least some of them in writing afterwards. And the webinar will also be posted on the Family Planning High Impact Practices website. So if you go to this brief on that website, you'll find a link to this webinar. Okay, so let's go on to the next. This is our second poll question. So go ahead and put that up. So click all of those that you think apply based on your experience. And while you all are voting, I'll just tell you that one of our presenters is presenting today from Côte d'Ivoire. She just happened to be there. And another of our presenters will be presenting from Mozambique. So some of us are here in Washington, some of us are in North Carolina, Côte d'Ivoire, and Mozambique. So let's give it a couple of minutes, a few seconds more. Okay, and another question about the handouts I noticed. The handouts are there. If you click on the arrow, you can then click on one of the handouts, right click, or just click on it and it downloads. And we'll also send you the links to all the handouts after the presentation if it's a problem for you. So let's see the answers to that poll. Okay, so 88% are pretty sure that they think it can improve knowledge, 62% attitudes, beliefs, and expectations, 52% self-efficacy, which makes sense. I think that's that's true. And then we have some skeptics in the audience who think, at least based on their experience, that it really can't do any of the above. Okay, thank you. So let's go on to the next question and then we'll start. Okay. All right. This is my little introduction here. So go to the next slide, please. I just wanted to give you a sense of how this fits into what we're doing in the Office of Population and Reproductive Health. We've been, for a number of years now, working on identifying what we call high impact practices rather than best practices. And these are supposedly evidence-based family planning practices that are vetted by a panel of experts that meets periodically and then documented by the authors of the brief in an easy-to-use format. So what we're hoping to do is encourage our missions and our partners to use these briefs to advocate for adoption of these practices, for doing their own planning and designing of their programs, for looking at the gaps in research that have been identified. So if a project is going to do some research, hopefully they'll look at these gaps before they do that, and to inform policies and guidelines and support implementation. The briefs are grouped into 3 categories. First one is called enabling environment, and those are the kind of structural, systematic interventions that kind of have to be in place in order for a high impact practice to work. So some of those are, health systems, advocacy, policy, and originally social and behavior change was in that category, but we've since created a separate category just for that. And then the second category is service delivery. And these are kind of changes in the way services are organized or delivered that are, I think, more concrete and more directly impactful on kind of outcomes and outputs. So these are things like mobile services, distributing family planning commodities in drug shops and pharmacies and things like that. And then there's social and behavior change. So this is a set of interventions which affect knowledge, attitudes, behaviors, and hopefully social norms that influence contraceptive use and kind of thinking about contraceptives. And then within those categories, if you can go to the next screen, there are kind of proven practices, promising practices, and categories of things that are not quite ready to even be called a promising practice. Proven means that we've just determined, or the technical advisory group has determined that there is enough evidence to say that this practice really does work, and we really strongly encourage everybody to implement it. And then there's promising, which is there's some evidence, but maybe we need more evidence to document that. And this brief falls in that category. Which we're happy about because, we feel like mobile technology, digital health hasn't been around for that long. So we feel like it's a pretty good achievement to get this as a promising practice. And just to give you a history, we originally produced a brief on M-Health, we called it. And Trinity, who's going to talk in a minute, actually worked on that brief as well. And that was in 2013. And that combined evidence on the kind of service and supply side with evidence on the kind of behavior client side. We've now broken those up and already produced a brief called Digital Health for Systems, which is one of the handouts in the handouts section. And that was published in 2017. And this is our final brief, which we just published a few months ago. So next slide. Just to tell you what the learning objectives are. Hopefully you'll leave this with a better understanding of what it means to talk about digital health for social and behavior change and what's in our brief. And hopefully you will learn from hearing about some of the implementations, successes, and challenges that the speakers and other people have encountered when they've been implementing SBC for digital health. So let's go to the next slide. This is our last poll before we actually speak, or our speakers start to speak. So let us know if you think that there is evidence that digital technology contributes to shifting social norms related to family planning or not. Let's see. So we're still, about half of you have voted, so let's wait a minute or two. And then we'll really get started. Not a whole minute. Okay, about almost three-fourths of you have voted, so let's see what we got. We have mostly yeses and some no's. So we have 74% yes, 26% no. Okay, thank you. Okay, can you put on the next slide? Okay, these are the panelists. We're going to start with Trinity and Tara. In a minute, you'll see their bios, and you can take a look at their bios as they begin to speak, and then they'll begin their presentation. So go ahead, Tara.
Okay, thanks so much, Peggy. So I'm Tara Miller. I'm a technical officer in the Research Utilization Department at FHI 360.
Hi, everyone. I'm Trinity Zan, a technical advisor in our RU unit of FHI 360.
And together with USAID, we wrote the HIP brief on SBC and digital health. Next slide. Next slide. Next slide. So Peggy already went over this background of sort of the evolution of the digital health HIP brief series. So we won't talk, for the sake of time, we won't talk about that much more. Next slide. I just wanted to share these terms that we use. You know, if you search for digital health or SBC, you'll find many different definitions. For the purposes of the HIP brief, we use the definitions that were created by USAID. So I'm not going to read them off, but just showing them to you for reference. Next slide. So the methods we used for this brief, we looked at peer-reviewed and gray literature for interventions and studies implemented in low and middle income countries. Our time frame was restricted 2013 to 2017 based on the previous mHealth brief that stopped looking at evidence in 2013. And we broadened our focus, our search terms, to this digital health. So as we already mentioned, the 2013 brief focused on mHealth, which was a slightly narrower focus, mostly with mobile phone technology. So this digital health was broader and looked at more linked technologies, such as mobile phones linked to cloud-based software, computer accessible dashboards, et cetera. And you can see those in our search terms. So we looked at things like social media, Facebook, Twitter, just to broaden the scope a bit. Next slide. So here you see our theory of change, which demonstrates the possible impact of digital technology to support sexual and reproductive behaviors on both intermediate outcomes and impact on increased contraception. So for intermediate outcomes, we found 6 studies that really focused on this third column, so these knowledge, attitudes, beliefs, self-efficacy, et cetera, and 5 studies that looked at behavior change. Next slide. Next slide. So before I jump into findings, I just want to highlight that there were major variances in the different studies that we looked at, both from study and intervention design all the way down to the way the outcomes were measured and reported, and the populations that were targeted and reached. So some examples of this, one study looked at the data using paired t-tests and reported a mean standard deviation, while others looked at pre and post intervention percent change. So also the target populations varied from very broad. So like one study looked at more general all men and women 18 and older in a large region in India, versus another one looked at women between the ages of 18 and 35 in one city in Nigeria. So broad to narrow, and I'm saying all this just to say that it was because of the heterogeneity of the different studies, comparing was somewhat challenging. And we talk a little bit more about that in the brief. Next slide. So this just shows where the studies were implemented. In dark blue, you see those that looked at behavior change. So those were in Cambodia, India, Mozambique, and Nigeria. And studies that showed only intermediate outcomes were implemented in Kenya, Tanzania, Hong Kong, and Ethiopia. Next slide. So to talk a little bit more about the intermediate outcomes, we really we define them in these 3 buckets. So the first one is that digital technologies for clients contribute to improving sexual and reproductive health knowledge, attitudes, beliefs, and self-efficacy. So 5 of the 6 studies that looked at knowledge showed effects, positive effects on knowledge of contraceptive options, knowledge of the menstrual cycle, locations of health facilities or where to get condoms, etc. 5 studies demonstrated a positive impact on attitudes and beliefs, including around dispelling myths and misconceptions, easing concern about safety and risks of different methods. And 4 of 6 studies that assessed self-efficacy showed positive outcomes associated with the intervention, including clients' ability to discuss family planning with their partner or healthcare provider, and perceived ability to effectively use a contraceptive method. So the second bucket, digital technologies for clients may contribute to shifting norms and increasing social support for healthy reproductive behaviors. I just want to make a note of the language here. So we use this word may, and versus the previous intermediate outcome. So knowledge, attitudes, and beliefs, we have a much more robust evidence base to support versus this one, we only found one study that, it wasn't even a direct aim of the study, but it was a text message intervention and implemented in Mozambique that found that male and female youth said that they viewed contraceptive use as a way to increase educational opportunities and express increased acceptability for a woman to use a contraceptive method other than condoms, which suggests a possible impact on social gender norms among participants. So this third bucket also uses that word may, and digital technologies may offer more options to reach young people. And this is suggested in the evidence where youth have said that they desire access to information about contraceptives that's confidential, private, and anonymous. And digital technology can help bridge that gap. Next slide. So before I jump into the outcomes or the individual studies, these are just some highlights of the behavioral outcomes. So our key finding was that men and women with sufficient exposure to digital health programming may be more likely to use modern contraceptives than those unexposed. So 3 of 5 studies that tracked changes in contraceptive behavior documented significant increases in modern contraceptive use. A 4th study found positive behavior change in some populations with certain contraceptive methods, and only 1 study found no significant change. So I say all this to say that the evidence base is still mixed. This advocates for the need to grow the evidence base around digital health for family planning behavior change, and it's also why this was coined a promising practice, and why we use the word may. So next slide. So this table is also included in the brief. You can look at it, reference it in your own time for the detailed information. I'm just going to go over a couple highlights from each of the 5 studies that looked at behavior change. So the first one was the Motif intervention implemented in Cambodia. It was an added component to a clinic-based service for women seeking post-abortion care. They used interactive voice response, or IVR messages, about contraceptive use, combined with the option to receive phone support from a trained counselor to discuss their chosen contraceptive method. And women that chose oral contraceptives or injectables could also opt to get a text message reminder. So Motif showed positive impact at 4 months, but no significant impact at 12 months. Next slide. So the CycleTel intervention was implemented to a more general population in India. It was a standalone SMS intervention where participants were pushed 65 text messages over a period of 16 weeks about a range of sexual and reproductive health topics. CycleTel was the only one that found no significant change in contraceptive use among participants at follow-up. And next we have the Encinas intervention implemented in Mozambique. It was an SMS-based intervention implemented among young men and women in 2 districts in Mozambique, and it did show positive increases in family planning use among certain populations. Katia Adamo will talk a little bit more about Encinas shortly, so I won't go too much into that. Next slide. And so the last 2 interventions we looked at were both implemented in Nigeria. One was Smart Client, and it was implemented among single women, and Smart Couple was among married men and women. It was a standalone IVR and SMS combined intervention that showed statistically significant increases in contraceptive uptake. And Caitlin Moore will talk a little bit more about that, those 2 interventions shortly.
Great. So now we're going to share just a little bit of information related to implementing these types of interventions. Next slide, please. For the sake of time, I won't spend too much time talking about these, and I know that we'll be hearing some more of this from our other two speakers. But the first bullet here is nothing new to those who have been working in SBC. This is a best practice that you must engage your end users at the beginning, in the design process, and throughout. Perhaps what's particularly unique to digital health are considerations around things like the type of technology that people own and are comfortable using. We're often more successful when we build upon what people are comfortable using. The frequency and the timing of messages, asking folks when and how they would like to receive content. And there are unique ways that you can do that through digital technology, and you can even build it into the technology itself, as Caitlin will likely tell us in her presentation. It also has to do with considerations regarding literacy when you make decisions around format. Privacy is something that is often brought up with related to digital technologies. Some of the privacy concerns for SBC are not as much related to the confidentiality of patient medical records, for example, which is more related to those systems level interventions, but there are considerations that need to be taken into account, specifically what are users' concerns about privacy? How would they like to receive information? How would they like to remain anonymous or not? And so those come into play quite a bit in these types of interventions. For budgeting, it's just a simple notion of identifying your cost categories, and there are tools out there to do so. And particular considerations for SBC-focused interventions often have to do with whether your costs are front-loaded at the beginning and whether they scale as you scale, which is often the case with SMS-based interventions. And those become particularly important when you think about the sustainability of your intervention and how you will maintain sustainability, what the business models are. And there's been quite a bit of learning over the past 5 to 10 years about various business models, whether you're asking users to pay, which has considerations for whether you can reach those at the bottom of the pyramid, or whether you might get private sector engagement. And there have been some successful case studies of partnering, particularly with mobile network operators. And so there's more information about that in the brief. And then finally, of course, with all of our global health interventions, we want to support robust monitoring and evaluation. And again, these digital technologies offer certain advantages, particularly building in real-time data collection to the platforms that allow you to sort of gather that information, review it, analyze it, and iterate quickly to make improvements. And there are various ways that you can do that, again, with more information in the brief. Next slide, please. So the priority research questions that we identify, as we noted earlier, this is a promising category. Therefore, we cannot say definitively that the use of these applications positively impacts contraceptive behavior and uptake. So that remains a priority research question, as does the question of which platforms are most effective in which settings. We do not yet know that, particularly because there are such a range of settings and a range of audiences that you can reach, which demands a bit more sizable evidence base. In addition, we do not have very much evidence about what the costs and the sustainability of specific digital health applications is in different contexts. So we're still in a phase of collecting that information. Next slide, please. These are some of the tools and resources. We're over time, so I will not highlight them, but they're available for you to explore. And I believe that's it. We have the references available there through the link. And otherwise, we thank you, and we'll look forward to your questions.
Okay, Caitlin, go ahead. Thank you, Trinity.
Thanks, Peggy. So my name is Caitlin Lair, and I am a program officer at Johns Hopkins Center for Communication Programs, currently presenting from Côte d'Ivoire. But today I'll be speaking about the Smart Client and Smart Couple interventions, which were developed in 2 countries but tested in Nigeria. Next slide. So, sorry, the rationale for the tools you can see on this slide, but in general, they were 2 tools conceived to serve different purposes, but complementary purposes. So the Smart Client tool aims to help women become informed, empowered, and confident users of family planning services and methods, whereas Smart Couple addresses couples, women and men together, to encourage joint decision-making, couple communication, and taking actions together related to the use of family planning services and methods. Next slide. So the two tools were initially conceived of as being independent, different, but ended up kind of merging, and I'll get to that in a bit. But they are interactive voice response tools developed by the family planning team of the HC3 project. We use the Voto mobile platform, and all of the content was recorded locally in both Nigeria and Cote d'Ivoire. So multiple language versions in Nigeria and then French in Cote d'Ivoire. We tested the content in both countries and then conducted larger user studies in Nigeria to test the effects of each of the tools. Next slide. So just a bit about the design of the tools. What makes them unique is that they use IVR to deliver interactive entertainment education content. So whereas IVR is generally more often used for a hotline type purpose where it's you listen to kind of short static messages, it's interactive, but it's not necessarily that entertaining. We wanted to have multiple segments in the calls and give the listeners the opportunity to choose which segment they listen to. So when they first called in, they heard the introduction and the drama, but then after that, they were given the option to listen to a variety of other segments, a testimonial, a sample dialogue, friend-to-friend chat, and then we had quiz questions within each call, as well as separate quiz calls. And if you go to the next slide, that provides just an overview or a depiction of the call structure. So you see, there's some automatic segments, then you get to the choices. And next slide. So to evaluate the effects of the two tools, we conducted two separate studies. The first we looked at Smart Client, and that user study had intervention and control groups. And then after that study was completed, we conducted a Smart Couple study, and that had just a longitudinal design. And both studies were conducted in Kaduna in Nigeria, and you can see the sample sizes. And one thing to note also is that in the Smart Couple user study, we used automated surveys that were at the end of the first call in the series and then the last call in the series. But one of the lessons learned that I'll talk about in a bit, with the attrition and people dropping off partway through the call, people weren't reaching the survey at the end of the call. So for the Smart Couple user study, we switched to in-person surveys in order to have a larger sample size. Next slide. So I realize that the numbers and the text is a bit small on this slide, but their full reports of both user studies are available online, so you can dig into that data if you want to. But as is somewhat visible here, all in the Smart Client user study, all 7 of the ideational and behavioral indicators assessed increased significantly between the intervention in the intervention group, while they declined or remain unchanged in the control group. So it's just some of the findings. Women were twice as likely to feel confident discussing family planning with a provider. Nearly all of the women at the online had recently discussed desired family size with their spouse, and the number of women using a modern method of contraception more than doubled. Next slide. And for the user study, or the Smart Couple user study, sorry, 8 of the 9 ideational and behavioral indicators increased significantly between pre and post intervention studies. And overall exposure to the tool was associated with significant increase in the score for ideation. So some of the highlights are higher exposure to the tool increased the odds of discussing family planning with one spouse 10 times for women, or 10-fold for women, and more than 12-fold for men. Higher exposure was associated with a 9-fold increase for women and a 12-fold increase for men in the odds of discussing contraceptive methods with a spouse. And let's see, higher exposure to the tool increased the odds of discussing family size, and also the last point that I wanted to make was that unlike the other ideational variables, exposure to the tool did not significantly change the extent to which the respondents had thought about their desired family size. So that was the only indicator that we did not see a change with. Next slide. So in addition to the user study, the surveys that we did at the baseline and endline, we also looked at the data, the analytics that were coming in through the platform, and we got a lot of rich insights from that. So the average duration of listening was about 5 minutes, almost 6 minutes for smart client, and then varied between 4.5 minutes and 5.5 minutes for smart couple, whereas some of the calls had 10, 15 minutes of content. So we were also able to see which segment listeners were dropping. Well, we were able to see exactly what time in the call the listeners were dropping off, but also which segment they were listening to when they hung up the phone. And this helped us realize that most of the participants were not accessing the optional segments. But what's significant about that is that we still saw the results that we did, even though they weren't listening to the full amount of content. And we also could look at the responses to the in-call questions and the quiz questions and notice that we had pretty low response rates, and that was one of the things that prompted switching the automated surveys to in-person surveys for the smart couple study. And next slide. So just some in conclusion, we saw significant positive results about the effects, and this points to the potential for IVR being used in this way and for this purpose. But we definitely would recommend significant changes to the tool to make the content more just more digestible, something that's more condensed, more accessible. But the participants did really enjoy the entertainment factor, and this is definitely, incorporating entertainment into a phone call is something that's new and exciting for participants. But at the same time, we had issues with attrition in the study, people either just not starting the calls or dropping out at a certain point through the series. So it's worth looking at, finding that sweet spot of how many calls people are actually interested in listening to. And then as for the duration of the calls, during the pre-testing, a lot of the participants were saying, oh, we want more segments, more content. And then we saw that they didn't actually listen to it. So, there's a difference between, pre-testing with certain people and then, the people who are actually using the tool that you have to kind of keep in mind. And then we did run into issues with people not understanding how to use IVR. So even though IVR is considered, very, very basic, it's still an issue of access and use that needs to be considered. And we ran into issues with literacy, with the SMS messages that we sent out as well. So next slide. So as I mentioned, all of the tools and the user study reports, the full scripts, everything is available on the HC3 website. And the lessons learned from the studies and from the development process, we put into an adaptation guide. So that's also available on the HC3 website. And I look forward to answering any questions that you may have as well. Thanks.
Thanks. Go ahead, Katya. You're up next.
Hi, I'm Katya from Pathfinder, Mozambique, and I'll be sharing with you the experience of MCNASH. Next. Hi. So I'll be sharing with you how we did use the digital health to reach youth with comprehensive sexual health information. So this is the outline of the presentation, why we do have mHealth as a feasible approach for young people in Mozambique, MCNASH as how we did scale up, and then I will share with you our lessons learned using this SMS mechanism as to deliver comprehensive sexual information. Next slide, please. So we do have a lot of opportunity. So we have a country with 28 million people and almost half of 13 million of use mobile. And we have limited access to healthcare. Around 67% of those live in underserved areas. So they are in need of information and services. Next slide, please. And also as an opportunity, you can see that from 10 to 24 years old, we have this high number of population. So it's a very great opportunity for us. Next. Next. So as our pilot intervention, we did implement with the USAID project. Next slide, please, Adas. We did implement with a USAID funded project, and it started from 2010 until July 2014 in 2 provinces of Mozambique. We had as a goal to have a greater access to contraception, reproductive health, and HIV services through youth-friendly health services. Next slide, please. The design of MCNASH. The design of MCNASH was based on the need of youth to have information and strategies to address a range of barriers to have this information. So using SMS, we utilized narratives and cornerstone of Pathfinder's behavior change approach. We based our stories and our experience based on the lessons learned from FHI 360, already a platform that they use. And we did complement the stories as a way for you to receive straightforward information on methods, and also a way to address sexuality and rights and reproductive health information. Next. We have 3 components in MCNASH. We do have story, and then we have information as in messages, and then we also have an interactive menu of questions on a range of sexual and health and reproductive health topics. Next. Next slide, please. So the development of the stories. We used as a tool Pathways of Change game to gather information about all the barriers and facilitators for contraception use, and use all of that information to generate initial stories. And at the beginning, 2 stories were developed for parenting and non-parenting youth. We had the storyline in 24 chapters, and those all in Portuguese, of course. And we also used testing slang, so youth could feel more, could identify and understand all the languages and stories in the messages. Next, please. So our target audience and enrollment. It is still a free service for youth. We have parenting and non-parent youth from 15 to 24 years. They have their own cell phone and ability to use text SMS, which is very good for confidentiality, as it was told before. And initially in the pilot, the enrollment was conducted by 20 peer educators from 2 youth-based community organizations of Matola and Inhambane, 2 provinces in Mozambique, trained to register youth in Mcinas. Next, please. So, as a total of enrollment in our pilot, from a period of September 2013 up to February 2014, we had 2,005 young people enrolled, and as you can see, most of them were from 18 to 24. Some less were parenting, 32%, and most of them were young women. Next, please. How we did scale up. So we went from 2 provinces. Next slide, please. We went from 2 provinces to 7 provinces. So in 2017, mostly in 18. So up to now, we do have 9,066 young people enrolled. It is a peer educator and also self-enrollment, and it comprehends, initially it was only family planning, but we did increase comprehensive information on sexual and reproductive health, gender, and HIV. Next, please. This phase 2, we do have this data. It's our first 6 months, and we can see that now we do have more young people from 15 to 19, and most of them, now the parenting status has changed. Most of them are parenting, and we continue to have female as most enrolled, and most of them also had a sexual experience. So it also shows a great opportunity and need of information and services for sexual and reproductive health. Next, please. This is our information on requests for messages, the frequently asked questions. So in this list, you can see our menu messages, the questions, and then we can see the number of requests. People really ask more if they are ready for sex and sexual pleasure, So this is some of the questions that they do really ask. Next slide, please. In this, you can see information about contraceptive methods, how they ask, and you can see that implants are the most asked for. So next slide, please. We had an evaluation after the pilot was implemented, and after the E2A evaluation, we can see that knowledge has increased. And we can see that even for females and males with and without children, they had at the baseline a level of understanding of this family planning and sexual and reproductive health. And at the end line, you can see that the knowledge has increased. Next, please. We have lessons learned from this pilot that we did implement, and that we are using this second phase to respond and address, which are the use of a local script writer, story-based messages, text message slang, and participatory design process with youth was very essential to build the stories and to make them more live, and people wanted to continue on reading them. SMS is an acceptable and feasible method to deliver sensitive and confidential information for young people. Intervention resulted in an increase of contraceptive knowledge, comfort, and even intention to use the methods. Integrating SMS intervention within larger service delivery projects is critical to ensure supply for demand. And narratives and interactive is the suggested best practice. Scaled SMS projects can become costly. So there is a need for business models and market research on willingness to pay for sustainability. And both experience suggest youth might be willing to pay for services. And in this, you do have the link for our evaluation. And Kani Mambo, thank you.
Okay, thank you, Katya. Thank you, Caitlin, and thanks, Tara and Trinity. Can we go back and do another poll? While you all are filling out this is the same question we asked at the beginning, so we want to know if you think we were able to share some convincing evidence that would change your answer on this question. So go ahead and answer that. And while you're doing that, I'll just go back. I have a number of questions. So I want to start with one that I think is directed to Tara and Trinity. And when we're done the poll here, we'll let them answer. But someone asked, are they only looking at interventions that are standalone digital interventions, or is there evidence of SBC with combined in-person activities and digital interventions? Okay, so why don't we give people a little bit longer to wait. I think that I would like Tara and Trinity to speak to that, and then maybe Katya could also speak to it, because I think one of her lessons was about how you have to integrate something like this within a larger service delivery project for probably a lot of reasons, but one is recruitment and kind of being able to then provide services once you've kind of encouraged people to have interest in those services. So let's go to the poll results and see what we have. Let's see, I can't see it. Okay, I don't know if this changed, but I'll tell you that when we send you the link to the everything, we'll let you know if anything changed. Looks like it went up a little bit. None of the above has 0 now, and improving knowledge went up, so that's great. Okay, can we go back to the presentation? Okay, and this is our final question. Go ahead. So do you think this webinar shared enough evidence that digital technology can contribute to shifting social norms? This is the bigger picture question. Let's see. Okay, why don't we stop here so we can go into the questions. So the answers are 77% agree, which is pretty good, 23% disagree. Okay, so let's go to that first question now. And Tara and Trinity, do you want to speak to whether or not everything that you looked at was a standalone, or were there some, besides MSANUS, I guess, that were integrated with face-to-face service delivery or other activities?
Yeah, sure. So in addition to MSANUS, we saw one other intervention, the motif intervention, that also had combination in-person services, and then also on the phone, like a hotline that clients could call. So those were the two that showed impact and behavior change.
Yeah, so it's just interesting because we do have those two that were embedded and showed impact, and then we also had Nigeria 2, which were standalone and showed impact, and then the other standalone, which was Cycletel, did not show impact. So it's very much that mixed bag, and again, that's why I think one of the conclusions is we just need a broader evidence base with more instances to be able to start to draw those conclusions about whether standalone versus embedded is more effective.
Yeah, and the same is the case for the intermediate outcomes. There was a mixed bag there too. So.
Okay, thank you. Katya, do you want to add to that by maybe speaking a little bit more about why you put that as a lesson learned?
Thank you. Well, first, luckily, we did have this intervention associated with a service delivery intervention. So, but youth is very difficult to a very difficult group to get access and also to inform. So it was fundamental to have them having this experience on technology and have information. So as long as we saw that their knowledge was increasing, so they were demanding the services. The intention to use was also increasing. So having them this demand to the healthcare, to the youth friendly services, we saw that it is really important to integrate this intervention, not make them a standalone intervention due to the need. So that it was for Mozambique.
Okay, thank you. I have a couple of questions for Caitlin that she actually typed the answer to, but I thought she might want to say a little bit. These were specific questions about actually how the IVR tool worked. So one person asked, was there an interactive element in the IVR? Another asked, how were participants chosen? And a third person asked about whether callers had to pay for the calls or were they free. So Caitlin, you want to answer those?
Sure. And just to tack on to the last question, the two tools were designed to be integrated within a larger package of activities. So they're not designed to be standalone tools, but that was just how we tested them. And in response to the question about the interactive element, as I explained, the calls were interactive in the sense that the listeners could choose which segment they listened to, that they wanted to listen to, as well as through the quiz questions within the calls, the multiple choice questions. So that was how we kept them interactive. And for the two user studies, the participants it was done random sampling to recruit participants to the studies. But if the tools were to be launched and used within the context of a larger activity or intervention. There are numerous ways that they could be promoted, and also kind of repackaged as well. So they could be promoted via health facilities, social media, mass media. There are a lot of different ways, like social mobilizers, etc. And the last question about whether callers paid for the calls. In our user studies and in the testing, the calls were all free to the users. And this was done through reverse billing, which is just a simple option, a basic option with the IVR platforms. So all the costs came back to us, the project. But we did explore willingness to pay in some of our pre-testing and follow up, and users were interested. They said that they would be willing to pay a small fee per call, but seeing as the content can be quite long and you would be charged by minute, I'm not sure that the project they would accept paying for the entire call. But I mean, it's definitely something worth exploring further, especially because it can get quite costly when you're paying per minute and per SMS.
Okay, thank you. I have a couple of questions for Katya now. One person asks, how does the MSANUS platform allow the people who are enrolled in it to ask questions? Kind of explain a little bit how it works, I think. And do they get like standard answers from a set of answers, or do they actually get customized answers? And what about the cost effectiveness of this project? You mentioned as it scales up, it gets more expensive. So maybe you could speak to both of those a little bit.
Okay, thank you. So this is they have access to standard answers. So they can have access, for example, for the menu, and then it's a drop-down menu. So they can ask for anything that they have on the menu, but they are all standardized questions. For the cost, yes, it gets expensive because we do subsidize the cost for every enrolled. So this is
something to think about when you start a service like that, right?
Yes, so this is something that I think Tara was speaking about, sustainability of these services. So for now, we are paying for them. So we do have to limit the access of self-enrollment. But we hope that during the E2A evaluation, we did ask some young people, and they answered that they were willing to pay for the service. So I think maybe someday we will have really to let them pay for the services, but for now we are able to pay for them.
Okay, thank you. The next question, I think, is for anybody who would like to answer. One of our participants observed that she rarely sees research in seminars like this, which focuses on online digital interventions other than under the umbrella of social media, in particular feature phone friendly mobile websites. Why is that? Anybody like to answer that question? And while you think about that, let me read the next question, which is another one that anyone could speak to. This caller mentions that there is a law in India which protects children from sexual offenses, and sending messages on sexual and reproductive health with such a law in place could be a gray area in India. So if anybody has any experience with that, dealing with that same issue in another country, that would be interesting to hear about as well. So anybody want to answer the first or second question?
Peggy, this is Trinity. I think
to the first question, we did find in our search only one article related to something that wasn't SMS or IVR, and that was a Facebook intervention. I don't exactly know why that is. One thing I just wanted to note is that even though we were doing an updated brief, most, all of the studies minus that one were SMS or IVR, which a lot of people would consider an older technology. There is the time lag between when something is implemented, when people collect data, and then the amount of time it takes to publish on that. So one could, hypothesize that we'll have more of that research coming out in the next few years. But that said, their example of, just kind of feature phones with web enabled, I think is a good one. And I don't really know the answer to why that is. I think there have been fewer, frankly, I think there have been fewer of those implemented outside of some of the kind of ComCare, and ComCare does, publish a lot about what they do, but it's more often in a broader bucket of also linked to, referrals made, supervision visits, enhanced, that type of thing.
Okay, thank you. Anybody want to talk about the whole issue of kind of sending information on sexual and reproductive health to younger adolescents where it might be a sensitive issue, such as in India? For example, for MSANAS, did you only accept kind of participants of a certain age, or?
Well, in Mozambique, there is no specific law prohibiting people to have access to this kind of information. But yes, there is. We do have people enrolled from 15 years old. We do not send message above that.
Okay.
But yes, but 15. Yes.
Okay. Well, we're a little bit beyond time, but we started late. So let me just ask one more question. We have some more that we'll have to put in the handout, but here's one that I think is interesting. This person noted that social media use is really growing, especially in developing countries. So how are we all going to shift from traditional digital tools like SMS and maybe IVR to using these new technologies, or how have people already started to shift in that direction? Trinity and Tara, did you find things that maybe weren't enough evidence to include in the study, but were kind of using new media?
No, I think it goes back to what Trinity said earlier about, this lag between what's being published. We only found the one that was looking at using Facebook. But really, I don't think that it's about a shift. I think it's about a need to broaden. So we know that SMS and IVR work, and I don't think that people are going to stop using their mobile phones or receiving text messages anytime soon. So I think it's really about just broadening the interventions available and understanding who the audience is and what they need and how to reach them.
Yeah. And I would say, again, sometimes it's the conferences where you get to hear some of that in a more timely fashion. So, for example, at the Global Digital Health Forum, which is coming up in December of this year, you often get to hear presentations of those types of interventions more recently. So that's where we're hearing more about use of Facebook or other social media platforms. We just haven't seen it in the kind of documented literature yet.
Okay, well, thank you all. Thank everybody who participated. We do have some unanswered questions, so I'll talk with our participants about how we could maybe answer them in writing. Just to remind you, you can look at the recording again. The presentation is available. It will include links to all the handouts, and we really appreciate your participation. We'll also give you a little summary of the polling as well. And thank everyone, and have a great day. Oh, and the next TIPS webinar is on social franchising, and that's August 23rd. So if you're interested in that, please sign up. Thank you all.
Thank you.